change. Okay.
I think we on now.
It looks like it's starting. Yeah. Yeah, I'm not too sure about worker after the admin control. Have you got the contact number for Andrew and the server team?
No.
No. I'll go and tell Kate what's going on. And she'll make the relevant call.
Good morning, everybody. Welcome to the Health Board meeting of the 30th of September. As usual, because of the COVID restrictions, we are not meeting physically in person. We're doing this remotely as we have on previous occasions, and we are live streaming this so that people can see the proceedings on the internet, which hopefully provides perhaps a greater degree of access and transparency than we have in normal times, but it makes some of the technical challenges a little greater. Can I just also inform those who are watching in that sometimes it will appear as if we're not paying attention. That's simply because we're looking at the papers off screen. And also we will be taking a short break at 11:30 to give people a chance to refresh. So, board members, welcome. Thank you very much for attending the meeting today. You'll be aware that we are using a slightly different format now for our meetings. So we've divided the agenda into two parts, essentially. There's the consent agenda and then the main agenda. And the consent agenda is designed for those items where there is little need for discussion and there aren't any points of queries. I should also point out, of course, that all board members have had the opportunity of asking questions in advance in relation to the papers. Those questions
Marcus, you're back on the screen so we can see and hear you.
Okay, thank you. I'm just having a conversation with the IT guys. Just hang on a sec.
Okay, I'll give you a reminder.
So, colleagues, I'm not quite sure. Can you hear me or not?
Yes, I can, Marcus.
Yes.
Yes, Marcus.
Okay, I'm sorry. There was some technical glitch there. We were cut off. So I will continue where I was before. So, colleagues, I think I was just explaining that we have the agenda now in two parts: the consent agenda and the main agenda. And the consent agenda consists of items which are the more straightforward, where there was no need to have a particularly detailed discussion, and the main agenda will be the items that require our deliberation. Everybody has had a chance, all board members have had a chance to read the papers and ask questions in advance, and answers have been provided to those questions. So that's quite an essential part of the meeting, really, and those questions and answers will be published in due course so that everybody can see what was asked and what the answers were. So, with fingers crossed that the technicalities don't trip us up again, can I begin by welcoming Paul Mears to the meeting, to his first meeting of the Health Board as our new Chief Executive. Lovely, Paul, to have you with us. Not the easiest start that you could have wished for, very difficult and challenging and fast moving times, but we're very pleased to have you on board.
Thank you very much, Marcus.
Can I also welcome today Ruth Alcalado, who is the Deputy Medical Director, who is attending on behalf of Nick Lyons. Can I also welcome in due course Mark Dickinson, who will be joining the meeting to present the report on the safe, sustainable and accessible emergency medicine and minor injuries and illness services for the people of Rhondda Taff Ely. Not the snappiest of titles. And I would also wish, if I may, on your behalf, to extend our best wishes to Liz Wilkinson. Liz, our Director of Therapies and Health Sciences, who is due to retire from the NHS, I think next month. After working for the Health Board for the last 12 months, Liz, as we all know, has been a very valuable member of the executive team, and we all wish you, Liz, all the very best for your future. Thank you very much. So, colleagues, apologies have been received from a few people, from Nick Lyons, as I've indicated already, and from Olive Francis and John Beecher from the Community Health Council, unless they've been able to join us in the last few minutes. Colleagues, declarations of interest, item 1.3. Can I just ask anybody who has an interest to declare in relation to any item on the agenda, please do so now. No, thank you very much. So we move on to item 2, which is the consent agenda that I mentioned previously. So this is, as I say, to enable us to focus our time and energies on those items where it's particularly needed. We have the consent agenda. I know everybody's had a chance to read the papers and to digest them over the last week. So board members, can I just ask, are there any items that are currently listed on the consent agenda that you would wish to move to the main agenda for a fuller discussion? Please indicate now if there are any such items. Good, thank you all very much. So we can move on to item 3, which is the main agenda. And as we can see, some very significant items here for us to consider. First of all, 3.1, can I just check, are there any matters arising from the minutes of the last meeting which are not on the action log that anybody would wish to raise now? No? Good, thank you. Then we move to item 3.2, the integrated governance section. 3.2.1, which is a very topical issue. Can I just before we start on that, Paul, as the chief exec, your report is in the consent agenda. Is there anything that you would wish to highlight for us? And I'm thinking particularly in relation to the latest information on the COVID outbreak before we come to item 3.2.1. Paul, can I hand over to you?
Thanks, Marcus, and thank you for the welcome. It's really good to be here at my first board meeting. As you say, the Chief Exec report that's in the pack, I think it covers about 3 days of my tenure. So the most of it was detailing some of the things that have been going on previously, where Nick Lyons was acting up for a few weeks before I started, and also Sharon. So there's nothing particularly I wanted to draw attention to in that report that needs further elaboration. What I would just like update on is, obviously, as you say, we are dealing with a very topical situation at the moment around our management of COVID-19. I guess just to sort of reiterate, as what everybody will know, is that obviously the 3 boroughs of Merthyr, RCT and Bridgend have seen significant increases in infection rates over the past few weeks, which resulted in the 3 boroughs being placed into a local lockdown situation a couple of weeks ago. We're still waiting to see how that has impacted on the overall community infection rates, which is being very closely monitored by Kelechi and his colleagues in public health. So obviously that is the backdrop, if you like, of what's going on in our local communities. And I guess in some ways it was to be expected that could play through into our own services, and that's very much what we've seen recently in the Royal Glamorgan Hospital. So just to update colleagues on that situation, as of yesterday, we had 82 confirmed COVID positive patients at the Royal Glamorgan Hospital. That situation had escalated quite rapidly over the weekend, at the beginning of the week. And we have currently 6 patients in ITU and have had 8 deaths at the Royal Glamorgan associated with COVID. So clearly the situation is very significant there, and is posing a challenge to us in terms of managing the spread of infection within the facility. The infection control teams, the local nursing teams, and Greg and his team have been working very closely with the colleagues at the Royal Glamorgan to make sure that we're doing everything we can do to contain the spread. There's full compliance with the PPE guidelines that are mandated for managing COVID in hospital settings. We are doing a lot of work to ensure that we minimise the spread in terms of not allowing staff to move about within the facility between wards, really restricting patient movements between areas to ensure that we don't facilitate spread that way. But it's very clear that we have a situation that's escalated quite significantly over the past few days. We've been working very closely with our colleagues at Public Health Wales also to understand and track back around how the infection is spreading within the hospital. And we've also been talking to them very closely about how we can increase the speed and capacity of our testing facilities. As you can imagine, with an outbreak like this, a key thing is to make sure that we are able to get rapid test results on patients to enable us to understand their COVID status, which then leads to how we manage that patient within the hospital. And it also is really important for us to understand and bring robust testing in for our staff. Public Health Wales have been very helpful over the past couple of days in providing additional testing facilities and also capacity at their labs to help speed up the testing of patients' results to try and make sure we get those results back as quickly as we can. But clearly, given the situation, we thought very carefully about how we were going to manage the safety of not just the patients who are in the Royal Glamorgan, but potentially patients who would need to come into the Royal Glamorgan for emergency treatment. So yesterday, having stood up our gold command structure within the organisation, we had a call with our gold team, including in that also colleagues from RCT Social Care, the ambulance service, Cardiff and Vale. And we reached the point of decision that we would close the Royal Glamorgan to emergency admissions from 2 o'clock today. We've worked very carefully, Ruth and colleagues clinically have worked very carefully to try and determine the optimal clinical pathways that will help facilitate that. And I think it's really important to just re-emphasise that we will be keeping the A&E department open. So people who are self-presenting at A&E will still be able to be treated there as they would expect. And we are also trying to maximise the amount of capacity in our ambulatory care facilities there, so that patients perhaps being referred by their GP can hopefully be turned around and got back home with a support rather than needing admission. But anybody who is either an ambulance transfer, ambulance 999 call, who's clearly going to need an admission, will be taken elsewhere. either to Princess of Wales, Prince Charles Hospital, or a small number may go to Cardiff and Vale at their hospital at University Hospital Wales, or so 999 calls will go that way, and then any patient who does present at the RGH who is going to need a bed will then have to be transferred elsewhere, and this is for the emergency patients. We've also, in parallel with that, cancelled all the elective surgery at the Royal Glamorgan this week, apart from 3 cancer cases that were deemed to be clinically a priority to be treated. Just a couple of other things just to sort of give some precision on. Paediatric services will remain as they are, and also we are just in the process of going through a risk assessment process for the reopening of the Tyrian birthing unit next week to establish how that can occur safely. So that's the current state of play. We've obviously briefed all of our staff internally and within the health board. We've briefed local council colleagues, we've briefed assembly members and MPs, and obviously we'll be reviewing the situation on a daily basis to monitor the impact that these actions will have, and hopefully be able to sort of get the services back to full operational activity at the RGH as quickly and when we deem it is safe to do so.
Paul, thank you very much for that. That's very helpful. As you say, a rapidly developing and changing situation, and I'm sure all our thoughts are with those people who have been most directly affected by this, and the people who unfortunately have died as a result of this very, very virulent and dangerous virus. So thank you, Paul. Thank you very much for that update. Which leads us quite appropriately on, I think, to item 3.2.1 on the agenda, which is the more general update on the pandemic and mass vaccination and seasonal flu planning, and demonstrating, I think, really how rapidly developing this is, because the paper was probably written a week or so ago, and there have been some big developments since then. Anyway, Kelechi, perhaps I can hand over to you just to draw to our attention the issues that we need to consider. Thank you.
Thank you, Chair. Good morning, everyone. In keeping with that theme of things rapidly developing, at the time this paper was written, we had a particular situation, and there's been significant developments pretty much on every aspect. But having said that, there are key elements of the paper that remain absolutely relevant. And so there are 2 broad things in this paper. One is a general update on where we are with the Test, Trace and Protect program, and also a general update on our prevention and response plans. And then there are 2 papers that I'm asking for the board to approve in relation to the COVID mass vaccination plan and the seasonal flu plan. I assume everyone's read the paper, so the key elements I would just like to draw attention to is if you like, the integrity of the Test, Trace and Protect program, which you will recognize that we pretty much spent all of summer building that program, making sure that it was as robust as possible, because we did expect that when we came out of lockdown, there would be an increase in cases, even if we didn't expect it to be so swift and so significant. But the integrity of our Test, Trace and Protect program clearly has been tested by the recent surge in cases that we have had in the community. The elements of the Test, Trace and Protect program set out in the paper hopefully gives the board confidence that the different work streams of the Test, Trace and Protect program, including contact tracing, testing for people in the community and for healthcare workers and social care workers, the surveillance program, the elements of the program that is around the Protect, which is enabling people who need to be in isolation and in quarantine to be able to do that. So those elements of the Test, Trace and Protect program, as I said, we spent the summer building those elements, and now they're essentially being tested. And as they are being tested, we're responding effectively, but we're also learning things that will hopefully put us in good stead to respond to any increase in numbers that we might expect over the winter. The second element of the program that I'd like to draw attention to is how we set out the escalation around the prevention and response plan, which you will remember we were required to submit to the Welsh government last month. We did that. And what that program does, what that paper does essentially set out the different thresholds for escalation. I'd just like to draw the board's attention to them. Essentially, what the story is that we have exceeded those thresholds, and it is fair to say that as far as the resurgence of COVID-19 is concerned, we are firmly in a resurgence in the community, which obviously has necessitated the current enhanced restrictions or lockdown that are in effect since 17th of September in RCT and a week later, both in Bridgend and Merthyr. So I'm not going to say any more around those elements of updates. But the other aspects of the paper that I'm looking for approval are in relation to mass vaccination for COVID. Now, the expectation on all regions, including the CTM region, is that we should be ready to vaccinate the public, make COVID vaccination available to the public imminently later in the month of October. Now, that is no guarantee that a vaccine will be ready, but I think the simple thinking is that it is better to be prepared if a vaccine was ready than to have a vaccine ready and not be ready to vaccinate the population. There are clear priority groups that have already been identified, and huge amounts of planning are afoot, and we've been communicating obviously with the Welsh government, keeping them abreast as they have required of our plans. It is fair to say we have submitted our first cut of our plan on the 3rd of September. We have had a feedback, and the feedback has been positive. So in a sense, I'm asking the board to cite that plan and be assured about the preparations that are afoot to make the COVID vaccination available to communities in CTM if it does become available as we hope. The second element that I'm looking for approval from the board today is the seasonal flu plan. Now, there have been significant changes that have been made to the seasonal flu plan, including extending the eligible groups, calibrating the availability of vaccination to the extended groups, and those extended groups are set out very clearly in the paper. And again, the board will remember that last year, for the first time, Cwmtaf Morgannwg met and exceeded expectations in terms of staff flu vaccinations. We use innovative approaches, including the use of peer vaccinators. Last year, we had 200 peer vaccinators. This time, we have more than 400 peer vaccinators. So we placed ourselves on very good footing to be able to deliver the seasonal flu vaccine. So that plan is there for the board to approve. I'll just say this and I'll stop. We already are in very, very challenging times, as you know. Going into the winter, we expect it to be even more challenging, and all of our planning, the integrity of our planning, will be significantly tested in the months ahead. And I just want to be able to give assurance to the board that staff and partners across CTM are doing everything possible to ensure that we can mount a competent challenge to the challenges that we'll be expecting over the winter. Thank you, Chair. I'm very happy to stop there and take any questions.
Kelechi, thank you very much. And I'm sure on behalf of the board, we would again wish to give our thanks to you and your team and teams in the local authorities too, because this, as you say, is very much a partnership effort. The enormous efforts that people have put into this in a completely unprecedented situation, and which shows no immediate signs of changing for the better either. So thank you very much for that. Colleagues, there may be additional questions that people wish to answer, and while you're just considering that, there are, Kelechi, I think, a couple of questions that were submitted in advance that we haven't been able to publish an answer to yet. So perhaps I could just ask you those now. The first is the report provides some examples of the likely reasons for the emergence of clusters throughout the health board area, and these include people returning from overseas holidays and working arrangements in the local factory. The question is, given that the recent significant outbreak in the Royal Glamorgan Hospital, do we have a full understanding of the reasons for this outbreak, and are we confident that any measures being taken in response will be sufficient to prevent any similar outbreaks in the Royal Glamorgan and in other healthcare settings?
I think it's, if I'm honest, it's very difficult to give 100% assurance that, first of all, we have perfect understanding of how this has come about, and that whatever interventions we put in place will work. We can only rest on the evidence of effectiveness of interventions and say, well, these interventions have been put in place in previous outbreaks of this nature and they worked. And so we can be relatively confident that putting them in place in response to this outbreak, we should expect similar results. So I think, first of all, the question of do we understand how this outbreak has emerged? We've been taking a very detailed look at our understanding of how this has emerged, and it is fair to say where we are, based on the information we have today, is the likelihood of what we call a super spreading event. And this is when one individual, whether a patient or staff, has been positive and then has passed it on to a number of individuals. So this, rather than multiple transmissions over a period of time, what we probably have is a single transmission over a period of time in a single space. In a sense, that's what we call a super spreading event. We think it is a super spreading event, and that is just based on the information we have as of today. That will not explain 100% because there will, in addition to the super spreading event, have been some degree of transmission, what we call nosocomial transmission. So we think a lot of it is explained by super spreading events that has happened in the context of our wards. In terms of the interventions that we have put in place, we think the interventions will take a bit of time to have an effect. But the delicate balancing for us is that if we're not 100% certain that they will have an effect, we don't have a lot of time, and that is our justification for, if you like, the extreme measures that we have taken in response to this outbreak. It is better to be extremely cautious, and hopefully that caution shows in the degree of interventions that we have put in place. The hope is that they will put the outbreak under control. But I'm afraid I cannot stand here and give confidence, 100% assurance that they will work. No one could possibly.
Thanks, Kelechi. That's very helpful indeed. And the second question really was around test turnaround time. One of the objectives, I think it's on page 17 actually of the main plan, is for test turnaround in 24 hours. And I know this has attracted a lot of concern in the community, hasn't it? How close are we to achieving that particular objective?
Recent data that I again saw very late yesterday, so apologies that I haven't been able to put it in this context, shows an improvement in the last week in test turnaround, but that is against a background of quite a decrease in performance on test turnaround, largely because of issues that are completely outside of our control. Now, you may know that a number of tests that are done in the community go to the Lighthouse Labs, which is under the control of the UK government. At some point, the Lighthouse Labs came under significant amounts of pressure because the demand for testing increased and the capacity to analyze the tests decreased at the same time. So there was a double whammy of impact on the Lighthouse Labs that ultimately affected our turnaround times. One of the ways that the Welsh government has been working with us to improve the turnaround times is to give more control to regions like ourselves and make sure that we have an increasing proportion of our tests passing through the Public Health Wales lab system rather than the Lighthouse lab system. It is likely going forward that we will have to keep a combination of both the Public Health Wales system and the Lighthouse lab system. So the improvements in the turnaround time will continue, hopefully, as we give more and more of our capacity to pass through the Public Health Wales system rather than the Lighthouse lab system. One other thing that we're doing to improve the turnaround times is to put in more capacity within Royal Glamorgan Hospital and Princess of Wales Hospital, particularly for analytical platforms, and Public Health Wales is working with us on this, and we're very grateful for the help that they have been giving us in getting more analytical platforms in-house so we can process more of our tests within CTM. I think that the turnaround times will improve over time. I cannot guarantee that there will be very, very rapid improvements.
Thanks, Kelechi. That's again very helpful indeed, and very straight of you, I think, which people appreciate. A number of questions are coming in from colleagues. Ian, come to you first.
Okay, thanks, Mark, and thanks, Kelechi. It was a very informative presentation. Probably a difficult question to answer. I don't know if you're able to answer this one, but we've heard in the press and in scientific papers that a lot of vaccine trials are now entering stage 3. I think they call it stage 3, which is the sort of the final stage of testing. Do we have any indication on what their efficacy is as part of the testing that's been going on, and if so, if we think they'll become available soon, or are we looking at a longer period?
Ian, you're right. It's a very difficult question to answer. If I had a crystal ball that I could gaze into, I might be able to give you a more confident answer. But I think the general thinking now, as you probably know, all of our planning for COVID vaccination is based on the likely availability of 4 different vaccine platforms. So those different vaccine platforms are ones that there is a significant degree of. Okay, I'll be with you in a moment. Go on. There is a significant degree of confidence that they will indeed become available before the end of the year. But having said that, all of that is still, there is no one who is 100% confident in the scientific community or in the policy community that those vaccines will be available. We have to work on the information we have today, and the information we have today is that there are vaccine platforms that are likely to become available before the end of the year.
Okay, thanks, Kelechi.
Thanks, Ian. That's very helpful. Maria, come to you next.
Thank you, Kelechi, for that. And you know, I'd like to thank you and your team for the amount of work that you've been, you've been able to manage during this this last 6 months. It's been exceptional, and the team has worked extremely hard, I have to say. Just 2 quick questions from me. The availability of the flu vaccine to meet the extra demand. Are we confident that we will have enough to meet that extra demand?
Thank you, Maria, and thanks for your appreciation of the efforts of the team. So make sure I pass that on. The quick answer is yes. We think that there will be vaccines, the seasonal flu vaccine available to meet the demand. However, the hedging of the bets there is about prioritization. So even though the eligible groups have been extended, everyone is not everyone in the eligible groups is going to get the vaccination at the same time. So there is a phasing that is hopefully going to take account of the fact that the availability of the seasonal flu vaccine will be calibrated to the demand within the extended group. So yes, we think there's going to be sufficient available, but if it is not, there are clear priority groups within the extended categories.
Yes, the reason why I ask this question is that on previous years we have run out of the vaccine, and with that demand being even greater on us, I was just interested to know what the position was on that one. The other thing is, and I think Alan has answered my question, was the need to use primary care to manage this this extra demand during this vaccination programme, both the vaccination programmes, if the COVID vaccine becomes available. And it's good to see that our GPs and our community pharmacists are on board with this. Is that correct?
That's absolutely correct, and we thank our primary care colleagues for their willingness to pitch in and help with the demand on the 2 that we're going to get with the 2 vaccine programs this winter. That's
very good to hear, because some other health boards have been very reluctant to get their primary care colleagues on board in relationship to this. So it's good to hear that our GPs and our community pharmacies are on board with this. Thank you, Kelechi.
Thank you.
Alan Laurie, perhaps you could just bring us up to date on that, because I know that you've been dealing with some issues very recently.
Three bits from me, Marcus. The first is there are a couple of practices that have had problems with their supply chain. and we have managed through medicines management to bridge that gap. We did it yesterday in 2 practices and we'll continue to do that. So the primary care department, medicines management and individual practices are working that one through. So that should not stop anyone having their flu vac if they were being booked in to do it. Secondly, the additional supply for the additional groups will be held centrally by medicines management. And as Kelechi has quite rightly said, depending on the demand for that, then they'll be allocated out from there. GPs were made very clear that they were to be doing the normal categories. They were very keen to do the over 50s as and when vaccine supply became available, noting that they would not have ordered that vaccine supply ahead of time. So that's why the central resource there that be well controlled. And then the third point, to just pick up where Maria is, I would place some gratitude to the LMC. The LMC locally have been working with all practices to encourage practices to participate in the mass vaccination programme across CTM, and we have had a very good response to that. Clearly, timing is all, because practices at the moment are flat out in terms of delivery of the flu vaccine. And as Kelechi has said, the COVID type vaccine probably is going to come a little later in the year, in which case practices will be in a better place to support us. We will keep monitoring that on a weekly basis, Maria, and we'll make sure that Kelechi's team and others are updated if there are any problems around that. I hope that helps.
Thanks, Alan.
Great. Thank you, Alan, Maria. Jane, we'll come to you next, please.
Thank you. Kelechi, again, impressed by the work of the team in putting together these plans and by putting them into practice. I want to pick up on a point which you reference in your paper. The availability of data and good data and the flow of that data to the appropriate places will help us really focus our resources and make best use of our resources. In your paper, you talk about one of the unresolved issues is data flow and how data will be transferred swiftly and efficiently to others, for example, GP practices. And in your answer to one of the questions raised in advance of the meeting, you told us that there's a new national system which has been commissioned to actually deal with this. Could you give us an indication of the likely timelines for delivery of this product by NWIS, the National Service? Because that seems to me to be quite fundamental in terms of how do we actually make sure we are using our resources most effectively?
So, thank you, Jane. The current guidance from the Welsh government is that, and this isn't an indication of when the mass vaccination is likely to start, but the current guidance is that we should be ready to deliver the COVID vaccinations by the 19th of October. So if, and this is not a date to be put out in the public domain, and that's why I'm stressing that is not the start date for the COVID vaccination. It is a date for planning for within the NHS and partners. So given that that is the mandate we've been given, I would expect that NWIS would make that system available well before that date, or before that date at least. Now, if you then extend the question by asking, are you confident that that's going to happen? Well, my answer is probably yes. And why am I confident? Because we did it for the CRM. So the contact tracing system was turned around. At the time, the Welsh government said, we're going to get the CRM ready for contact tracing. The turnaround was incredibly quick, and there wasn't confidence that that was going to happen, because anything IT raises questions. But actually, the Welsh government turned around with NWIS, a reasonably good system to support contact tracing across Wales. I do hope that NWIS will draw on that form, that experience, and turn this one around in similar time.
Thank you.
Thanks very much, Jane. And Phil, we come to you.
Thank you, Marcus. Thanks, Kelechi. Kelechi, can I say I always read your daily bulletins and your graphs, your data, your tables. May I say they're all very bona fide. That's more than I can say for a few people of late. But anyway, on the antibody testing, Kelechi, this is a little area of, I'm a bit in grey about this. We have tested around 10,000 through educational staff and healthcare staff since May, which is great. Tell me, could those tests taken at that time change in months later for those individuals? You know, it doesn't make them say, are they immune from the virus, or does it make them less susceptible, or, you know, but does it change at all, or will we have to be doing more retesting of those individuals?
Based on what we know today, from all of the evidence, from all of the studies on antibody sustainability, with the antibodies, so if an individual tests positive for antibodies, at least based on data, we know that at least lasts at least until about 128 days. What is 128 days? At least four months at least. That doesn't mean that that's how long it lasts, but we just have data to show that it is stable for at least 4 months. Now, the presence of antibodies to a disease does not necessarily translate into being immune to that disease. And at this point, we do not have any evidence to suggest that the presence of antibodies for COVID-19 guarantees immunity for COVID-19. And that doesn't mean it doesn't. What I'm just saying is that we do not have any clear, confident evidence to suggest that having antibodies guarantees that you are immune. The only other thing to say is, from what we know from recent studies, immunity to disease is different from immunity to infection. So there is recent evidence to suggest that even though the antibodies do not guarantee immunity to infection, in other words, you can have antibodies and still get reinfected. However, what they do is that they guarantee some degree of immunity to disease itself. Now, that becomes a little more complex, trying to distinguish between infection and disease. But just to give a very simple example, somebody can be positive, and in terms of feeling the impact of the disease and the impact of the disease is significantly attenuated, that does not mean that they couldn't catch the infection. But I think all of that is from recent scientific evidence. None of that has come through to policy, quite understandably, because the evidence is not compelling as yet. All we know at this point is that the presence of antibodies does not guarantee immunity to COVID-19.
Thank you, Kelechi.
Kelechi, thank you very much. I don't think we have any more questions from colleagues. Thank you for the paper. Thank you for the continuing effort. I guess it's clear to everybody that this is, as everybody says, an unprecedented situation, that we are encountering these problems on this scale, possibly for the first time ever. It's a disease that we are only getting to understand a little bit as time goes by, and there are still, as you've quite rightly said, so many unanswered questions about the disease itself and about its impact and how to prevent it. And there is an enormous amount of work going on by our staff, but under your leadership and by the local authorities, as a huge effort. And as you quite rightly point out, the rest of it is down to the community, isn't it? It's about how people behave, the choices they make in their lives, people's ability and willingness to follow the guidance that's issued. And it is very tough ask for people that is being made. So, Kelechi, thank you very much indeed for that paper. Thank you.
Thank you.
Colleagues, we move on then to the item 3.2.2, which is the Annual Assurance Report on Compliance with the Nurse Staffing Levels Wales Act. And I hand over to you, Greg.
Thank you very much, Chair. So this is the annual report of our compliance, as the Chairman's just described. So this will be the second report I've brought to this board. There are several appendices attached and following the All Wales agreed format in board reporting. So over the last year, every board will follow the same prescriptive process. So I do apologise for the number of papers, but it's key that the board members have visibility of the detail. I just have a few highlights of the report I'd like to take you through, if I may. So page 2 sets out our statutory duties under the Act, and you'll be aware that we use a triangulated approach when we calculate staffing levels, and by that I mean we assess the acuity of the patients, we assess the professional judgment of the ward sister and the senior nurse, and the nurse sensitive outcomes, so the harm measures. So by undertaking that triangulation approach, we'll come out with the required staffing levels. The Act, 25B of the Act, is very clear that you need to include all of your medical and surgical wards, and you'll be aware that over the last 6 months, due to our COVID challenges, we have moved a number of wards many times. So the 30 wards I would have presented to this board in January look very different today in terms of case mix, although I can assure the board that the staffing levels haven't changed. All the detail of the ward movements are found in Appendix B, and we are required under the Act to ensure that we clearly document when we change a medical or a surgical ward around. There is additional requirement in this report under the Act, and that's to articulate the impact of any care quality issues due to not maintaining adequate staffing levels, and also whether the maintenance of staffing levels played any part in patient complaints. So just to clarify, so the four issues we need to align to whether or not we have sufficient staffing levels and whether patients came to harm: pressure ulcers, falls leading to significant harm, medicine-related incidents, and finally complaints. Through our current incident reporting system, there isn't any evidence to suggest, although the numbers are very small, that not maintaining staffing levels has had a detrimental effect on patient harm. Although, just a word of caution there, we are reliant on staff input in a DATEX report if the staffing levels do not meet the planned levels. So, and anecdotally and through my own observations, if there is a deficit in numbers of staff within our wards, then regrettably patients do wait longer for fundamental care deliveries and sometimes to have their call bell answered. So whilst there's nothing empirical coming through our information systems, that's not to say that some of the deficits in our staffing levels isn't having an impact on patient care delivery. We need to work with our localities to ensure that all of these incidents are reported. As previously reported to the board, currently we don't have an electronic mechanism to capture consistently the planned against actual staffing levels. So, you know, how much of the rota actually played out on the day. Although I've been working with our All Wales group on our healthcare monitoring system, which we currently use for assessing the healthcare standards. And there is a functionality now that we're currently piloting, which I will bring to the board in November. So future reports hopefully will see a planned against actual staffing level compliance. If wards are down for staffing levels on any particular day, all of our sites have 3 times a week staffing meetings where the senior nurse and the heads of nursing will ensure that nurses are redeployed to areas of the greatest risk. And there's a whole myriad of interventions that we've agreed across Wales in terms of reasonable steps, which are set out in Appendix E of the report. And just finally to mention, if I may, we undertook the biannual audit of all of our Section 25B wards back in July, so the medical and surgical wards. Early indications to date that there will be no adjustments required to the establishments on these wards, but I will formally report that back to the board in November. And in terms of board colleagues that like the detail, the assurance report in Appendix A sets out all of the progress over the last 6 months on compliance with the Act for 1920. Thank you very much, Chair.
Greg, thank you. Thank you for a very full and very honest and transparent report, which I think board members very much appreciate. Nicola, I think you've got a question.
Thank you very much, Chair. Thank you very much, Greg. I appreciate these are really difficult times on our staff. I just wanted a little bit of clarity, Greg, on the pilot where we will include the rostered to the deployed. In the pre-posed question, you said that a pilot had been undertaken, but in November 20, but now you say November 20. So I think just a bit of clarity there, Greg, on when the pilot will be, please.
Of course, yeah, thank you, Nicola. So we have piloted the healthcare monitoring system. Didn't quite get the results that we'd anticipated in terms of what the system could feed out to give us a level of assurance that we were capturing the appropriate information. So we've gone back around the houses, to be fair, Nicola, and we've reinstigated the pilot now, and currently, and we're all doing it as an All Wales Nurse Director group. So when we report the 3-year report required by the Minister next year, then we'll all have consistency in our reporting. So you're absolutely right. We did pilot it back probably just pre-COVID, didn't quite get the results that we'd required. COVID then hit us, and we're following the pilot now.
So have we actually got it in our DATEX reporting yet, Greg?
No, we don't know. We don't have it yet, and it won't be in DATEX reporting, Nicola. It will be in the healthcare monitoring system. Currently the systems don't talk to each other, but it will spit out the information as we currently get the information through the healthcare monitoring standards. So it will be the same system, but not DATEX.
Great, thank you, Greg. Thank you, Chair.
Thanks, Nicola. I can't see any more questions coming from colleagues. So, Greg, can I thank you for the paper? I think this is really encouraging, and clearly this is work in progress, as you've described. It's a crucial bit of our armoury to ensure that the quality and safety of care we provide for patients is at this level that we would want it to be, and it's very helpful, I think, to have a statutory framework in which to do that. And you have very honestly and transparently described the work that is in progress, because we're not yet in the position that we would want to be, but we're working hard to achieve that. So, Greg, thank you very much.
Thank you.
And then moving on, colleagues, item 3.2.3, which is the organisational risk register. Another key bit of our ability to ensure that the organisation is run for patient safety and the quality of care. And a lot of work also has been going on in this area too. So, Callie, can I invite you to talk to us about this? Thank you.
Thank you, Chair. I'm pleased to present to the board today the Organisational Risk Register in its new format. We've done a lot of work over the last 12 months, particularly in the last 2 to 3 months, and I hope that board members will see from the Risk Register today that we've sort of completely reformatted, and we've also looked at how we articulate risk in relation to the if-then resulting in format. It's still very much a work in progress. We're just still mapping our risks against the risk management strategy, and a lot of work is ongoing with our integrated locality group. But we also thought it was important to bring the organisational risk register here today to the board to see the progress that we have been making. The report's very detailed, so I just want to pull out a couple of key areas. You'll notice that in section 2, we've identified and highlighted all the progress and steps that we have been taking. There are a number of risks on the risk register relating to COVID-19. This report was completed and received by the Management Board prior to the recent surge in infections. So I just want to reassure the board that we are re-looking at the COVID-19 risks on the risk register at the moment. They will be reassessed and will be considered at the Management Board in October and be brought back to board thereafter. So I just wanted to provide a bit of assurance on that. We had a very successful board development session on the 3rd of September, where as a board we explored our risk appetite and our risk tolerance discussions, and also around our principal risks. So just wanted to sort of present it in its new format today, acknowledge the significant work and position we are in now from where we were perhaps 12 months ago, and just say that this is a journey that we are still very much going forward on. I would imagine that there'll be a more detailed report to the next meeting as we have the work from the integrated locality groups feeding in, hopefully by the end of October. So other than that, there isn't anything else I was going to pick out. I'm happy to take any questions on where we are with the risk management process, and obviously our executive team can take any questions on any specific risks, although I know we did have some questions in advance that have been answered. So thank you, Chair. That's all I wanted to cover.
Thanks, Kelly, and a very helpful presentation, I think, which nicely captures a lot of the work which is ongoing that you're leading on our behalf. So thank you very much for that. Colleagues, we've had an opportunity to ask questions on this beforehand, and we've discussed it on various occasions. I can't see any additional questions coming now. So, Kelly, thank you very much for that item. I'm going to suggest, colleagues, that we just take a quick break now, just 5 minutes if we can. As part of our good practice, that we should have these breaks. So colleagues, if I could ask you to come back at 11:30. Thank you very much. Right, colleagues, thank you very much for coming back so promptly. We move on to item 3.2.4, assurance proposals. George, we've had a chance to look at this in before the meeting. Is there anything particular you want to draw our attention to?
Thank you, Chair. Nothing in particular. I think, well, I would hope it's self-explanatory. It reflects on the proposal that went to the board in January. The first part of the report covers the elements of the proposal that we have managed to cover. The second part talks about those that due to COVID we've been unable to do it. And it proposes effectively the re-establishment of the bi-monthly meetings for both PPF and People and Culture committees. We'll need to keep this under review clearly because this paper was written at a time before our infection rates went up, and we did stand down some committees, you'll recall, due to COVID, so that will have to be kept under review. But at the moment we are proposing keeping the October board meeting in as scheduled, but meanwhile the increase in the other committees is what's being proposed effectively here. More than happy to take comments, but I have spoken to a couple of independent members who are supportive of this. The executives also are supportive, with the caveat that it is kept under review.
Super, thanks, George. And I think there've been various conversations, haven't there, which have led to this. So, colleagues, can I just make sure that you're happy to approve the introduction of the bi-monthly committee meetings for PPF and the People and Culture committees? Thank you very much, George. And then we'll move straight on to the next item, which is also yours, 3.2.5, about the COVID-19 Gold Command structure of delegation.
Thank you again, Chair. So in the Chief Executive's report, which was on the consent agenda earlier in the meeting, Paul confirmed that Gold Command was stood up on the 21st of September in response to the infection rates of COVID in our communities going up. And as a result of that, we've looked at the scheme of delegation, and you'll recall that during the first wave of COVID back in March and April time, we did put in a decision-making matrix to support that urgent decision-making that we reflected on earlier. And so we've adapted exactly the same concept, amended it ever so slightly to take into account the reputational impact of some of the issues that we'll be dealing with. And it's attached to the appendix, and I endorse it to the board for approval.
George, thank you very much. Looking for questions. I don't think we've got any from colleagues, so we're asked to approve the summary of delegation which is attached. Can I take it, colleagues, that you're happy to do that? Maria, I think you've got a question, sorry.
Yes, thank you, Chair. George, can I just ask, in the decision-making log that you're going to be having as part of the Gold Command scheme of delegation, the last time that we went into this position, it was available to board members and independent members at sight of this. Is that going to be the position now? Because that was very helpful.
Certainly, Maria. We're in the process of putting together a specific risk register, because obviously we have only just re-established gold, but as we did last time, Maria, we'll make sure that the gold risk register is made available to all board members, and it will be updated as frequently as it is as we meet as a Gold Command meeting. And the decision-making log, again, certainly we can make sure that that is made available to all independent members.
Thanks, George, because that was very, very helpful in the past 6 months and kept board members up to speed on what was going on.
Yeah, thank you. And just probably one other thing to note is all of the decisions you'll see, the whole basis of the decision making that we're asking the board to delegate to Gold, Silver and Bronze Command will be backed up by quality impact assessments and risk assessments. So that process will all be undertaken as well. So just to give that added reassurance.
George, thanks very much. This is about ensuring, isn't it, safe governance, but also being agile and responding to a situation that really does change almost by the hour, certainly by the day and the week. Thank you very much indeed, and I think we are, colleagues, happy to approve that scheme of delegation. Thank you. So we move on to the next section then of the agenda, which comes under 3.3, which is about quality and safety. The first item there is 3.3.1, the maternity update. Greg, over to you. Thank you.
Thank you, Chair. So this time I provided the board with a number of documents, including both the summary paper, the 3 workstream reports, the POW targeted piece of work, and the neonatal self-assessment against the RCOG recommendations. And finally, obviously, this has been an iterative piece of improvement work, our newly formed maternity improvement plan, which has been validated and scrutinised by our IMSOP colleagues. So just a few key messages, if I may, when this report was written, which is obviously just over a week ago. So 57 of the 79 RCOG recommendations now complete and verified by IMSOP. Several areas of slippage, as you will see, identified within the report, although all now back on track, with the exception of job planning, which Dr. Accolado and Dr. Lyons are supporting the teams on this. The clinical review process is progressing, and we have increased some resource within our maternity improvement team in order to ensure that we respond to the IMSOP and the clinical reviewers' timeframes. So we have put that extra resource in. The targeted piece of work within POW, it was based on some concerns that was raised through our own monitoring systems in relation to some timeliness of escalation care issues. I am pleased to report that this work has been ongoing for a number of weeks, and the outputs have now been validated by Welsh Government and our IMSOP colleagues at the formal board. And the lessons learned from some of the challenges within POW have been shared across the other obstetric unit. Again, there are, this is a journey of continuous improvement, as we've said many times at this board, although we did map out some short and long-term actions for board members to review on page 7 of the report. And of course, a big push now on the leadership and culture piece, which regrettably we had to stop in the height of COVID, but that programme commences virtually next month. No specific risks that I feel I need to highlight to the board based on the work over the last several months. Although clearly, again, it would be remiss of me not to be concerned around our ever-growing coronavirus concerns. And of course, we do have a number of midwives that are pregnant, and we need to ensure clearly the safety of the midwives if we get to a position where we need to restrict some of the services. But currently, as we stand, we have good staffing levels across all of the units. And as the Chief Exec announced earlier, we are still working through the Tyrian risk assessment process. And then finally, and apologies, I didn't include this within the pack, we've had the 4th IMSOP report, which was published this week. And the team are very pleased with the report's content. Not to say or to be complacent, we still know we have a long way to go, and women and families have been affected, and clearly don't want to undermine that, but we are pleased that we've had recognition that our maternity improvement programme is continually progressing. Thank you.
Greg, thank you for the report, and again thank you for all the work that is going on. As we've said on many occasions, this is all about learning from the past, and the legacy of that experience is in the improvement of services that we are still seeing, and which still, as you quite rightly say, have some way yet to go. Colleagues, any questions? Nicola.
Thank you very much, Chair. Thank you, Greg. It's me again. Greg, it's obvious there's a lot of hard work going on by everybody. I just wanted to pick up on two things, if I may, please. I think it was in our July board, and it is referenced in the papers, that a questionnaire was submitted to maternity staff regarding culture. And given the small amount of staff that work there, 130 people have participated, I think is incredible. I just wonder, have we got any time frame on some analysis of the findings? Yep. And when we might plan on feeding that back to the staff, please? That's my first question. And then my second one is, there's a reference to the emotional intelligence training that took place. And I think the attendance at the first one was quite poor. Yeah. I'm just wondering how or what are we going to do to support our staff to ensure they can attend when we rerun them, please?
Yeah. Thank you, Nicola. And I do apologise for not responding to these questions you posed previously, but I do have some information which I think will help. So you're absolutely right. We had 125 responses to the cultural survey. Oh, just a word of caution to add, most of those are from midwives. So yeah, I think we still have some work to do in relation to the MDT. That said, we've done the first cut of analysis. So 80% of those came back as very positive, which we're really encouraged by. And we had actually some really helpful constructive comments from staff, some qualitative comments around new ideas or further improvements that we could make. So that was great actually to hear. We are taking the full report to the MIB 6th of October next week or the week after, and then of course I will ensure it's in the next board report, but clearly can share the outputs with colleagues prior to that. In terms of the emotional intelligence study session, to be frank, not quite got underneath why we had such a poor show. Talking to Val, you know, we did have specific concerns around staffing on those particular days, but nevertheless that may be one reason. We haven't quite got underneath the element of other reasons, which we're hoping will come out on the 6th of October at the next MIB, Nicola. So can update you after that if that's okay.
That's great. Thank you, Greg. And it's really good to hear that staff actually put some qualitative data. Yeah. Because, you know, when we just look at numbers, it's really difficult to give us some ideas of some ways forward to support the service. That's really excellent. Thank you, Greg. Thank you, Chair.
Nicola, thank you. Jane, we come to you next.
Thank you, Chair. Greg, as you know, we scrutinised these reports in quite some detail at the last Quality and Safety Committee meeting. So I won't go over ground that we covered there. But picking up partly on Nicola's points, but also on the information you gave us about the restarting of leadership training. It's very clear that leadership and culture of maternity units is one of the most fundamental factors in how they perform and the safety of the services that they deliver. I mean, that's been clear in the press nationally over the last couple of days. And putting that together with the need for these training sessions to be bringing in midwives, but also doctors. How are we going to ensure that we do have multidisciplinary training in leadership, particularly given the way the report that we have in front of us already shows that there are differential take-ups of things which are professionally important, like prompt CTG and gap and grow training, where the difference between the different professional groups is something that I've remarked upon over time. So, complicated question. Can you help me with that?
I will do my best, Jane. So yes, if you recall at the beginning of our improvement journey, and I think this is a lesson, you know, for the Maternity Improvement Board and myself also, we segregated initially the leadership and culture training, and there was always a view for the staff groups to come together. On reflection, it probably would have been better to instigate MDT training from the very beginning. But there were some specific staff groups that we felt needed some bespoke support. I think where we are now, and Howell may be able to help me with this, the recommencement of the programme is very much multidisciplinary. And again, you know, that comes with its challenges in terms of service. So whilst, you know, from a medical perspective, 6 to 8 weeks are required to come off clinical duties, you know, if there are specific issues on that day, then regrettably medical, midwifery, therapy staff would need to go back into service to secure the safety of our women and families. So I think probably this time around, much more focused on MDT training, multi-professional training. It's going to be virtual, so I don't think you won't get the same flavour or same connectivity as what you would get when you're in a room face to face with people. But nevertheless, you know, we need to progress with this now. It's been on hold for a number of months for very good reason. But I think, you know, we're very keen now that, you know, the remaining 20 recommendations we have in the RCOG initial report, most of them are focused around training, education, leadership and culture. So we have to progress with this. Ideally, we'd like to do it face to face. That's not going to happen for obvious reasons. And we'll just monitor the attendance as we do regularly, Jane. And, you know, both Ruth and Nick are great at stepping in and, you know, supporting our medical colleagues if and when we need that to happen. I don't know if Howell, oh, there you go, Howell can come in. Thank you, Howell.
No worries, Greg. Just to add to that, really, so I support everything Greg has said there. Had a very useful discussion actually last week with the Director of Midwifery and indeed the Clinical Director for Obstetrics about this very issue, Jane, in terms of reinvigorating some of the cultural work that we had commenced, in particular the emotional intelligence work and indeed the leadership programme that Roffey Park Institute had been working with us on. Now we're going to need to be creative on that front because, as Greg has mentioned, it's not an ideal way to do that via Teams or other electronic means, but there is still plenty that we can be getting on with. So we met really just to reinvigorate that. There's some work going on now between my team and the Director of Midwifery and Clinical Director, really just to take a quick look at the plan, make sure we've got multidisciplinary team working covered off in the way that Greg has suggested, and also we are continually reflecting on the feedback that we're getting from staff in terms of culture measurement, which is a key part of the work as well. So yeah, that meeting happened last week and that work is now underway.
Grant, thank you, Jane. And Paul Mears, we come to you next.
Thanks, Marcus. I mean, just to reiterate really what Greg said, and as part of my sort of induction, I've been going around and meeting lots of people, as you can imagine, and part of my time has been spent with the colleagues in both midwifery departments at POW and PCH, and I have to say, you know, clearly Val as the Director of Midwifery, but also her local sort of heads of midwifery in each department were really clear with me about the work they were doing to sort of drive the improvement from a leadership perspective. But I think also, I know also that they are involved with a lot of the cross Wales work around things like prompts and all the various initiatives that are underway across Wales with colleagues. So I think I've been reassured in terms of the conversations with the sort of leadership team within the maternity services. But as Greg rightly said, the key thing now is to make sure that we do that across sort of all levels in the service and not just focus on the midwifery service, because I think a key part of this is also where the obstetricians and other members of the multidisciplinary team play in. So it's really important that happens, and we encourage that to happen by freeing people's time up.
Paul, thank you. That's very helpful. Colleagues, I can't see any more questions that people want to ask. So Greg, thank you. Maria and I, with you, met the sort of senior leadership people of 10 or so people, midwives, doctors, just less than a couple of weeks ago. And certainly I think we were really impressed by people's energy, people's enthusiasm, people's determination, but also that sense of self-challenge. There was absolutely no sense there of complacency. These were professionals who were challenging each other to make sure that they were doing all that they possibly could to address the challenges that we know we've still got. And just one other little bit of update. I was buttonholed yesterday by a father who was very recently had his first baby, and how delighted he was with the care that they had received in Prince Charles Hospital. So that was just a nice little update. But as we're all aware, long way still to go, and an excellent team working really hard on that, and engagement from the staff, lots of encouraging signs there too. So Greg, thank you again for the paper. Colleagues, we move on. Item 3.3.2. I'll read the whole title. Safe, sustainable and accessible emergency medicine and minor injury and illness services for the people of Rhondda, Taff, Ely. Mark, delighted to welcome you to the meeting. We've had a chance to read the paper, but just draw our attention to the key issues, if you would. Thank you.
Yeah, thank you, Chair. And I think, as you indicated, it should be a reasonably self-explanatory paper. It reminds the board of the decisions made back in July, the drawing of a very clear line under the previous work, which was predicated in terms of the South Wales programme recommendation to end the emergency medicine department at Royal Glamorgan Hospital, and to reframe the work in terms of sustaining that service, and the board giving a very clear commitment to maintain the service, the ED service, on all three sites. So just to pick out the key points, so the main body of the report gives an update on what we've been doing as a project since. So we've done the mechanics of putting the project structure into place, of establishing a project board and agreeing a project implementation document, all the things that go along with doing things properly. But then most importantly, work has been progressing under the different headings that are illustrated in the appendix that shows how the different work streams of the project interrelate. I think particularly importantly is the work on directing patients to the most appropriate service, and to some extent the work on the design of minor injury and illness services now falls very squarely within the wider work on across the health board and nationally on phone ahead arrangements. And the whole issue of people making a phone call when they need to make contact and receive treatment from emergency or minor injuries and illness services. And so there is a separate project on that's been led by Alan, and we are not seeking to tread on the toes or duplicate the work of that, but we are regarding that project as delivering the work that was originally allocated as a work stream within this specific project. So we're maintaining close links there. In the meantime, through Amanda Farrow's leadership and with the support of the ILG management in RTE, progress continues to be made with the filling of posts and the strengthening of the establishment at the Royal Glamorgan ED. And so there's a summary there of both where we stand at the moment and some of the ongoing recruitment. And I just draw your attention to two advanced nurse practitioner posts have been advertised, and there is a lot of interest being generated in those posts. In parallel, we've got a working group looking at maternity services and making sure that we have a design of sorry, not maternity, pediatrics, sorry, hangover from the previous item, pediatric services, and ensuring that the pediatric service at the Royal Glamorgan can provide appropriate support and interface with the ED. And there's a number of options under consideration, which will result in a formal proposal coming back to the board no later than November. Now, very importantly, and obviously a great interest to the board and generated discussion at the July meeting, is the establishment of the Partnership Forum. And members of the board will probably have seen the comms that went out earlier this week through the board's website and social media channels, formally seeking expressions of interest from the public in RTE in becoming members of the partnership panel. I'll pause there, I think, for questions. Clearly, the paper was written and the work to date was written in the context prior to the events of the last couple of days in terms of the temporary curtailment of services at Royal Glamorgan. There's obviously been some comment from members of the public in social media that are sort of drawing a line between this work and the suspension of ambulance admissions into the ED at Royal Glamorgan, and you know, a number of implications that's part of an intention to reverse the decision to maintain the service in the long term. And just to state categorically, clearly members of the board don't need reminding of this, but I'm aware this is a public meeting, that the commitment of the board remains absolute, and this work will continue. We may have impact on this project from the current COVID situation, but we remain committed, both as an organisation and as a project, to maintaining the sustainable service at Royal Glamorgan.
Mark, thank you, and certainly as chair of the board, I would absolutely reiterate what you just said. There is absolutely no intention to go back on our decision earlier this summer, and the COVID crisis hopefully is one that will be resolved quickly. Thank you, Mark. That's very helpful. A couple of colleagues wanting to come in. Paul Mears, come to you first, Paul.
Thanks, Marcus. Thank you, Mark. Nice to meet you first.
I'm
meeting lots of people for the first time over the past couple of days. A couple of things. I mean, just to reiterate what Marcus just said, absolutely, and I've been very clear in all the communications in the past 24 hours that this is a temporary arrangement because of the circumstances that are in play at the moment at the Royal Glamorgan, but absolutely committed to making sure we restart as soon as it's safe to do so. A second point I just wanted to ask was, obviously, I appreciate very much that this is about the model of care for patients that are centred around the Royal Glamorgan. But I guess a question really is how also are we making sure that this piece of work from an ED perspective is also linked in with the other two sites? I'm just thinking that there's lots of opportunities with a health board running 3 emergency departments. Yeah. There are lots of opportunities to cross-learn about things that worked well in one place that could be transferred to another. And secondly, also thinking about the staffing model for the ED or RGH, you know, have we given thought to opportunities around using technology for things like remote engagement with, you know, we might have a consultant on call who's on site at PCH who could be patched in via video conference to the RGH if there wasn't a consultant available, or vice versa. So I'd be really keen that whilst this focus is very much on the RGH and the model that we develop there, just making sure that we're exploiting opportunities to look cross departments across the 3 sites to maximise learning.
Yeah, and there's an absolute commitment that we do that. That specific question of technology we haven't formally looked at it at this stage, but no, that's a point well made, and we will pick that up. But there is an absolute commitment to maintain communications across the 3 EDs and to share learning both ways.
Thank you. Thanks, Mark. Maria, come to you next.
Thanks, Mark. That's a very comprehensive report and brings us up to date on what's happening, and thank you for that. Can I just ask you, before you go any further around the public engagement, I just was wondering, you know, I see that you have a deadline date by the end of September for any expressions of interest.
Yeah.
Have you had any so far? Because I think it's absolutely critical to take those public with us around setting that model of care around our RGH ED department.
Yes, those expressions have started to come in, and I was in email contact with colleagues in communications earlier in the week, and almost as soon as the call went out, we had at least one very strong application almost by return of post. So yeah, no, that's looking positive, and I think one of the things we're aware of is that we may receive more applications, more expressions of interest than would make a workable panel, if you like, and so we are also thinking about how if we're sort of blown over with a wave of people wanting to get involved, potentially we could have, if you like, concentric rings of involvement, that we might have a core panel but a wider group that we might use virtually to sort of bounce ideas off and so on.
Thank you, Mark, because that was my second question. It was around if we had lots of expressions of interest, we wouldn't want to dampen that down, because we want people to have their views as to how we would manage that. So that's been very helpful. Thank you.
Thanks, Maria. Mark, just a question from me. In terms of the board's continuing oversight of all this, it would be really helpful to have a sort of a program now going forward, so that we can just see the timescales and what's involved, and then secondly, so that the board is always cited on whether we are meeting the milestones and so on. Is that
very happy to provide that.
Great, thank you. That would be very helpful. And obviously this is a key issue for the board, and the board itself, not just committees, but the board itself will wish to be satisfied that this is progressing at pace. So thank you very much. Good, colleagues, I can't see any other questions on that. So Mark, thank you very much for the work.
Thank you for the opportunity to present.
Thank you. And colleagues, moving on, then we move to the next section of the agenda, which is about planning, performance and finance. And the first item here is a regular and crucial one, the integrated performance dashboard, item 3.4.1. Claire, clearly you've provided it to us in advance. We've had a chance to pore over it in some detail, but maybe there are a few key issues you want to highlight for us. Over to you, Claire.
Thank you, Marcus. As ever, the performance report always elicits many questions from board members in advance. So there were just 2 points that I wanted to draw colleagues' attention to, and then I was going to bring in Alan just to respond to 2 of the questions that we haven't been able to respond to in advance of the meeting. So if I may, could I draw colleagues' attention to the bottom of page 3 and the top of page 4. I just wanted to reassure members that as we are looking to develop our integrated performance report, and more importantly the broader reporting arrangements that we work through the health board, that you will see in this report how we are looking to make sure that we are aligning our measurement approach, and that's measurement in terms of our outcomes, our outputs and our inputs, and we are looking to align those to our strategic objectives. And so as this report develops in the coming months, you'll see that more and more, that our strategic objectives are the things that we are looking at to guide us, to understand how we're performing against them, and then to be able to make the decisions that are important to all of us to ensure we keep on track. The other bit that I would flag is that in order to ensure that that happens, we really do need a truly integrated performance report. And so we need to make sure that that balanced approach that we described when establishing our strategic objectives flows through into our performance report and our measurement. And so I've had some very, very positive conversations this week with the Assistant Medical Director for Quality, and also then the Assistant Director for Quality and Patient Safety. And we are now looking to make sure that when you receive this report in the coming months, that it truly is an integrated report. At the moment, you'll see that in the cover report, we try to make sure that we're covering off our quality aspects, but perhaps it doesn't feature as strongly as it should in the appendix in the dashboard. But hopefully you'll begin to see this change in the months to come. There was nothing else from the report that I was going to draw colleagues' attention to, because, as I say, the way that we now run the report means it's very much easier for members to interpret and ask appropriate questions beforehand. It doesn't need me guiding you through it. But I do note that there are two outstanding questions, one relating to delayed transfers of care, a very pertinent topic given where we are with COVID and working with partners about ensuring we have capacity in our hospitals, and more importantly to make sure that our residents are receiving the right care in the right place for them. And then there's also a further question on urology capacity and the steps we're taking to ensure that our cancer patients are getting timely care. So Alan, I think that you do have a response to those two.
Yep, in relation to, first of all, in relation to urology, it is disappointing that we've got these breaches of our cancer targets. It is, I'm afraid, down to the issues associated with surgical treatment, which obviously we had delayed for the first 4 months of this year. We have, across all 3 sites, as we've described to board members before, instigated those green islands, as we call it. As you'll have heard right from the very beginning with Paul, in RGH this week we've had to take down that due to the situation there. However, we were prioritising urological cancers and lower GI cancers through all sites. However, certain patients are not able to be done in the Vale, which would have been an option for us due to availability of kit and also the severity of their illness and the concerns thereafter in relation to requiring critical care. So it is absolutely in our sights. Obviously, the next couple of weeks with the situation in the Royal Glamorgan is going to throw that off a wee bit, but the prioritisation placed on clinical need is where we're at, and we should start to see as we move through the next month an improvement on that. It is not about surgeon availability. It is very much around the fact that we've been limited in what we can do in terms of our capacity, and you'll see that in the lower GI figures too. In relation to delayed transfers of care, as very pertinent right now in relation to the need for us to ensure we can maximise capacity on the PCH, RGH and POW sites. Our colleagues are working hard with our local authority colleagues to make sure that we're making the very best use of available care home capacity across the piece. A number of care homes are closed to admissions. Clearly, we are working in relation to this safe transfer of discharges out, and that has slowed things down a wee bit because we do not want to be in a position whereby patients are discharged from any of our 3 district general hospitals or our 3 community hospitals to a care home with any risks of COVID associated with that, and that has taken some time. Today, each of the local authorities are working through with their nurse directors, ILG and our clinical service group managers to give us a feel for exactly what we will be discharging over the coming 48-72 hours. My expectation of our close of play today is that the numbers of people delayed on the site will come down, and I've already seen significant actions during the course of the board meeting relating to colleagues both in local authorities in Powys, over in Caerphilly, in Neathport Talbot, and also in RCT. So my expectation is that figure will be coming down. Clearly, it's important to do so as part of a winter protection plan, which will be coming back to the board and the RPB at the end of October.
Good, colleagues. Thank you very much. Thank you, Claire and Alan. Any additional questions that anybody wants to ask? Just pause for a second. Yes, Paul Griffiths. Paul.
Thanks, Marcus. Good afternoon, Claire. When I read the report, I noticed that you were putting plans in place to improve elective treatment capacity, which is running currently at about 30% of previous years. And I think there were plans afoot starting this month. And I use that just as an example, if I may. I not particularly want a full explanation about elective treatment capacity. It's more about the agenda that you were pursuing. To what extent is that going to be impacted by the upsurge in coronavirus and the way we've had to react to the situation in Royal Glamorgan Hospital? Is that going to provide a major obstacle to future progress?
So I'll respond to that, Paul, and no doubt Alan may wish to follow up as well. So I guess your question has 2 points to it there. So if I can take what we're planning to do and respond to that initially. And the next item on the agenda is actually me giving you all a verbal update in terms of the plans for Q3 and 4, but I will touch on it lightly at this point. As we are developing our plans, Paul, and as we have been building our capacity over the summer months, we are building in an amount of COVID activity into those plans. And we've been using the most up-to-date modelling as it comes out of Welsh Government to influence the amount of COVID capacity that we need to set aside, for want of a better phrase, within our hospitals. And that then allows us to understand the impact on elective capacity and to take the steps that we need to take to maximise those opportunities and create the green islands, for want of is the phrase that we use, as big as we can, where we're looking to utilise the Vale Hospital as an additional resource, maximise the opportunity there. We're looking to use the facility that the Vale has in Cardiff Bay to make sure that we have endoscopies. We're looking at mobile units for MRI and CT scanners to be able to bolster our diagnostics. So this forms part of our planning process, but it's predicated on that core amount of capacity that would be available to us on a planned basis for COVID. And clearly that's not a flat line. We're beginning, there is a peak, and as a consequence of that peak, we will see our elective capacity squeezed. But as I say, we look to make sure that we have mitigating plans in place so that we can maintain as much elective capacity as possible through the winter months. Now, all that being said, that is our planned approach, and it is our strategy, to use your terminology, is to make sure that we have our essential services. I think we've talked about these over the last few months. Our essential services are maintained alongside COVID capacity through winter. Now, there are now steps that we are taking that we wouldn't have been able to plan for. There are extraordinary circumstances, and we can't ever predict. I know that Kelechi is no longer able to be on the call, but Kelechi's words of caution earlier on around how good we are at predicting where COVID is going. There will be times where we need to move from our operational planning approach into an emergency response, and undoubtedly that will have an impact on our elective work, and we will then have to program in that change into our plans as we iterate these on a very regular basis.
If I was to add in, Claire, I suppose picking up from that, what we have done, Paul, is we have looked at what our emergency take it would be in terms of bed numbers over the period of the winter, and we've assumed that it will be the same as it has been, or an average of the last 3 or 4 years. What we don't know is whether any of that reduces as a result of the COVID impact, and we will monitor that on a live basis moving forward, because that would squeeze one way or t'other where we were going. Secondly, we have got absolute precision in relation to those people who are waiting in those 3 stages, stages 1, 2 and 3, and we had very clear profiles about how those patients were going to be treated. and we can dynamically now work through as a result of knowing that. So if we take lists down as we have done in the Royal Glamorgan for the next 2 weeks, what does that mean in terms of those patients, how we reprofile those, and in terms of clinical urgency, if there are patients on those lists that are being taken down, whether we reprioritise those into PCH, POW, the Vale, Neathport Talbot, or Cardiff Bay. One of the difficulties for us will be staffing. So if we have got significant increases in ITU rotas and capacities around our anaesthetists, that takes away from their ability, as it did in the first peak, to undertake planned work. So we are currently working in relation to how we could expand work at Neathport Talbot. If those anaesthetists have to be withdrawn from Neathport Talbot and used on the POW site, again, that can have a significant impact. What I would say is we've got a much better handle dynamically on what that looks like week on week than we've ever had before. What I can't give as a reassurance is that we will be not eating into that capacity over the course of the coming 3 to 6 months.
Okay, thank you, Paul.
Sorry, Ruth, did you want to add anything to that? Ruth Alcalado?
Thanks, Marcus. I think most of it's been covered, but I think I would say one of the things I would say is that, you know, this approach going into our second peak is going to be different, and I think that's what you just had outlined to going into our first peak, because we didn't know what we were facing in the first peak. You know, everything was pretty much cancelled, with then starting to put some business through the Vale, whereas now we are in a position that every patient on a waiting list has had a risk assessment and has been appropriately prioritised. And whilst we can't say exactly that we're going to carry on doing as what we had planned, as we need to respond dynamically to the situation, each patient is prioritised and will be looked at carefully to make sure that they get their treatment in a timely fashion. So I think I would want to give a degree of reassurance that this is different going into the second peak than it was going into the first.
Okay, thanks, Ruth and Claire and Alan. That was very helpful. As you probably gather, I am concerned that just as we seem to be putting plans in place to improve the position, we've been hit by this second wave, and I was just very concerned what impact that was going to have on everything that we've been planning to do over the next few months. So thank you. I understand that better now. Thank you very much.
Thanks, Paul. That's very helpful. And that's a nice segue, really, I think, isn't it, into the next item. I should perhaps just let colleagues know that Kelechi Noam has had to leave the meeting because he is chairing the incident management team for the RGH. So, you know, quite understandably, he's needed to leave the meeting for that purpose. So, thank you very much for that item, and then let's move on to 3.4.2, which is closely linked, isn't it? And Claire, this is yours, I think, as well.
It is, and apologies, members, that you don't have a paper in front of you today. We had hoped that we would be sharing our Q3/4 plan with you today, but we only received the guidance from Welsh Government late last week. And so what I want to do today is give you a little bit of an update, some of the key points that contained in the guidance, and then undoubtedly Alan, Howell and Steve in particular may wish to just follow up in terms of how we are taking our integrated planning approach forward through developing this 6-month plan. So just to be really clear, we all know and have received the Welsh Government Winter Protection Plan, which was published by the Minister at the beginning of September, and what we've received as an NHS body at the end of last week was guidance on an operating framework that responds to that winter plan. It also is very specific about how the role of the Regional Partnership Board in developing winter protection plans and ensuring that we work in partnership to put in the right solutions and plans for our population must be maintained and be a key tenet throughout our planning process. The deadline for submission of our draft plan is the 19th of October, and we are on track to be able to deliver against that deadline. and we will then submit to board, as we have done in previous occasions, to the October board, health board, for scrutiny. Yes, Phil, as I pick up some of the comments, it is really important that we align the work that we're undertaking with that of the RPB, and Welsh Government are very explicit that that is the expectation in the plan. I suppose I want to reassure colleagues that we have not waited for the guidance to be issued prior to starting planning, and I think some of the conversation that we've just had reinforces that point. All of the work that we have been doing over the summer months through our resetting programme is actually building us up to the point where we can have a solid foundation for the winter. So I suppose before colleagues come in with some more detail around aspects in terms of the operational, workforce and finance aspects of the plan, I suppose I just want to also draw to your attention that the more that we get into this and the more the planning horizons move out, so initially from Welsh Government and ourselves, we were talking in terms of 3 months programmes with a rolling 6-week cycle of plans. We're moving from that quarterly 3-month picture into a 6-month picture with this plan, and very soon Welsh Government will be asking us to develop our plan for next year, and we do anticipate that's a full year. So as we're moving our planning horizons, we are taking a decision to move away from our resetting programme workstream approach, which was appropriate as a governance and a delivery method when we were looking at very short-term picture, to looking to embed the work of our resetting even more into our core business, because it really is moving into core business. So that transition from emergency response into a focused programme of resetting, and then we're for the coming months moving into more core business with integrated locality groups and systems groups. We are proposing at the end of this quarter to stand down our resetting programme and then move the work that needs to be maintained into management board. So I just wanted to inform colleagues that that was our approach. So very much headlines from myself. We are on track to deliver on the Welsh Government, and more importantly on a plan that we need as a health board to guide us through what will be some very tricky months to come through winter. Alan, Howell and Steve, is there anything that you would wish to just highlight at this point? Our modelling, workforce and finance aspects are key underpinning aspects of this plan.
Howell, do you want to? You've appeared on the screen, Howell, so I presume that means you want to talk.
It does indeed. Yeah, sorry, we were having a very British polite moment there where I was waiting for Steve to start talking and he was waiting for me, I think. So I think, you know, it's worth just noting for the benefit of board members really that the workforce challenges. So, you know, Alan has already alluded to those earlier on in presenting a previous item, but board members will know that we have a challenging picture around nursing vacancies as a health board during, if you like, more normal times. We've had a bit of success over the last few months in terms of recruiting overseas nurses. We've brought in approximately 100, and we plan to bring in a further 100 over the coming months, international travel restrictions permitting. However, clearly we are going to be utilising or needing to utilise our existing workforce quite creatively as we go through this potential second wave, and the demands upon them in terms of mass vaccination, any increase in activity that we discharge, as well as winter and second surge are quite significant, and that may result in us needing to prioritise our efforts over the period. What we can do, and we have had some success in the past, is in the recent past, is bringing in fairly significant numbers of unregistered workforce. So we continue to explore that as a possibility to support teams, and indeed then working with partner organisations around us creatively. So, for example, St John Ambulance and other organisations of that nature, in terms of whether there's any support that can be provided there. But it is a challenging picture at a time when you would imagine the level of abstraction, so the time people spend out of the workforce through things like sickness and other measures, is likely to increase. Which means that obviously testing and turnaround times will become a key part of the picture for staff during the period. But we are working on that and working through that with ILG colleagues at the moment.
Steve?
Yeah, I'll come in on the finance. So within the guidance that we've had from Welsh Government, they've given us some clarity on the sort of financial allocations for the second half of the year, which is really welcome. So in essence, that indicates that we will receive a general allocation of 56.2 million plus specific programmatic allocations for things like TTP, mass vaccinations and so forth, but also including for urgent emergency care programs, and in particular the Contact Ahead program that was referred to earlier in the discussions. So our understanding of what that will mean is that we will have sufficient financial resource over the rest of the year to do what we need to do and help us meet this challenge over the next 6 months, which is really welcome. Alan, did you want to come in next?
Yep. I guess for me, the issue that we're picking up there with Claire was in relation to the winter protection plan. So for me, we have had each of our integrated locality groups pulling together a winter protection plan. We've had a couple of drafts of that and a more finalised version over the course of the last week, which is costed up in terms of schemes that we always have as part of a winter plan, new ones as part of a winter plan, and thinking through how that works on a multi-partner basis. We will be compiling that together, and we will need to have that pulled together so that we can get it both signed off for the health board as part of Q3 and Q4, but also for the RPB, because there's an expectation that regional partnership boards have seen what we intend to do as a region across a multi-agency sort of setup in relation to our delivery of the winter protection plan. It's not all about the NHS. It is absolutely a joint effort around that. So that is work that has been done and will be featuring as part of the Q3, Q4 and the RPB winter protection plan. I think that was it from me.
Colleagues, thank you very much. That's very helpful. Phil, you've got a question, Phil.
Yeah, thank you, Marcus. Thank you, Claire, et al. Moving from reset into a core operation is encouraging and good news, and that's been made. That's good news so far for everyone. I'm just thinking of moving away from resetting to a core operation. Claire, are we now calling it near normal from new normal? And if so, what new words have to come into play? But no, just as importantly, Claire, how will they touch on staff challenges in a different way? Are we just wondering how our staff are seeing this steady progress being made? You know, have they been able to complement the changes as well?
Sorry, Phil, the line wasn't great there, so I'm going to have to interpret what I think were the questions, but come back to me if I've slightly missed it. Firstly, on language, I'll be guided by you. There's so many different versions of new normal that could be used. I think it's important, actually, in terms of our messaging, that we maintain resetting as a term. You know, we are continuing the resetting. I think it's the urgency and the focus that perhaps is changing. We still need to grow our organisation into something new and different in response to COVID, and I don't think we would say that we have completed the reset. In terms of whether staff are feeling the impact, I know that we've been trying to make sure that we take staff surveys and pulse information to see if we can get that feel and picture. And I think the feedback is, it's been really intensive, and so staff are feeling the continued pressure of the work and the timescales that we are working to, and I suppose that's the bit that is being felt at the moment. People can feel the opening up, and that's a positive, isn't it? The opening up of our elective capacity, but actually the number of competing demands that we have on all of us at the moment, compared to where we were focused on a single challenge back around Easter time, sometimes that competing demand can bring even more pressure than we'd previously experienced. So I suppose it's a positive and a negative, Phil, I think, is the feedback that we're getting.
Yeah, thank you, Claire. That's fine.
Thanks, Phil. Paul Mears, come to you next, Paul.
Thanks, Marcus. It's not really a question. I guess it's just to reiterate some of the points that Claire made. And I know Claire and I and Nick and I and others have had various conversations over the past few days. Because clearly, in some ways, resetting it's almost, we don't really know how long we're resetting for. And I suppose in some ways that's why in some way making it more sort of core business really says, for the foreseeable future, we're going to be in this situation. And I think it's also important to say, obviously, even pre-COVID, we had some challenging waiting time challenges that were already there. So this is about us looking at all of these patients and making sure we've got a proactive plan for them. I also think, there's an opportunity here to think a bit creatively about how we address some of the elective pathways. So some of the conversations I've had with clinical teams in the sites over the past 10 days or so, we've talked about various sort of innovative approaches to how we do, for example, things like day surgery to try and help increase capacity through things like that, looking at other opportunities around some of the diagnostic procedures, working in partnership with other organisations. I think in some ways this challenge we face now, both from a COVID perspective and the number of patients we want to try and treat, is going to force us to think quite innovatively and perhaps challenge some of the thinking that we've had historically about how we delivered elective services. And I think that's going to need to be done across all 3 sites, because I don't actually think we're going to be able to, each ILG isn't going to be able to solve this problem on their own. We're going to have some cross ILG approaches to some of these challenges. So I think it's really important moving forward that we use the opportunity of the collective knowledge that we've got within our clinical community to help us think through some of these challenges and perhaps tackle some of the things we know need sorting, but perhaps have been on the back burner previously.
Thanks, Paul. That's very helpful too. Colleagues, I'm just seeing whether anybody else has any questions. I can't see any more. Claire and colleagues, thank you for this item. This is such a critical issue, isn't it, for us now? We know that with every week that passes, there are patients who would have received treatment in the past who aren't receiving treatment now, and that's a desperately serious situation for us, but more particularly for all of them. So getting our capacity up to something near where it needs to be is a huge challenge for us, with huge health implications for people. So thank you for the work you're doing, and I'm sure as a board we'll wish to keep a very close eye on this. So as soon as there are concrete proposals of paper for us to consider, then we would be very keen, obviously, to do that, and I know you are to prepare it. So colleagues, thank you very much for that. I should also just note for colleagues' benefit that Ruth Alcalado, the Deputy Medical Director, has had to leave also, I think, probably for issues relating to the ongoing pressures in RGH in particular. So Ruth has had to leave us for the moment. Thank you. We move on then to item 3.4.3. The finance paper again. Steve, we've had a chance to read it, but what do you want to draw our attention to in particular?
2 points really. The key one for the month we're reporting on, which is August, is that our deficit was 3.6 million against a projection of 4.5. So we were below what we were projecting. 2 reasons for that really. Firstly, some slippage on our gearing up around TTP, but also we're starting to see or we have been starting to see, I guess that's going to go now, a levelling off of some of our pay costs as the situation stabilised, and board members can see that from the sort of trend graphs at the back end of the report. So in the month itself, we've had a lower than projected deficit. I guess the other thing just to stress is the report was written before we've had the guidance from Welsh Government on the further allocations, and so projects a deficit of 56 million for the year. In light of the allocations we're going to receive, then, as I said before, we're pretty confident we will be able to respond in Q3 and Q4 within the resources that we're going to be given, and so from a future month would expect to be projecting break even, and in addition, we talked earlier around risks, and there is a financial risk on the risk register that we would have COVID costs beyond our funding. Well, clearly we need to rescore that risk and significantly reduce it or eliminate it. So that's another positive. Final point I just wanted to make is that all this funding that we're getting, which is really, really welcome, is just for the current year. It's not ongoing into next year. Clearly, a lot of the pressures we're under and the response to COVID and resetting will continue into the next financial year, and we don't know at the moment, no one knows what the funding settlement will be for health as we go into next year. So we just need to recognise that there is, a recurrent financial pressure, and as yet we don't know what the funding for that is, but it's really welcome that we're in a better position in respect to funding in the current year. So that's all I wanted to flag, Marcus, unless there were any questions.
Steve, thanks very much. And in case you're thinking it's because of interference on the line, the finance director did actually say all this extra money we're getting. Colleagues, any questions that anybody wants to raise? Looking, I can't see any. I think the paper really was very helpful, Steve, and completely recognising, as we've said on many occasions today, this is a fast changing situation, and when we think we're getting some certainty and stability, the world moves on again, doesn't it? So, but thank you very much, Steve. That's very helpful. Good. Colleagues, let me move on then to the last main section of the agenda, if I may, people and culture. Item 3.5.1 is a thing that we've discussed, I think, at each of our last few board meetings. How do we manage the risk, particularly to those, I think, 900 or so staff who are statistically, at least, at higher risk from COVID-19, and how you've been leading on this. Thank you.
Thanks, Marcus. So I assume you've read the report, but I guess there's two elements to this for me. One is around the Health Board's risk assessment of its several hundred BAME staff in relation to the COVID-19 risk assessment process. And you forgive me, the data doesn't appear to have come across terribly well into admin control, so I'll just read through a little bit of that. And the second then is around the Health Board's establishment of its BAME network, which is a new development for this Health Board. So in relation to the numbers, so you may be able to see if you click through the images that are available in the second attachment, that the completion figures have changed quite drastically and dramatically since the last time we reported the figures into board. So in the majority of cases, the compliance rates are around about the 90% plus mark. But for one specific area, which we are hoping to conclude over the coming days, up to a higher level of compliance. So that essentially gives us some assurance that the risk assessment process has been undertaken. There are a number of staff who remain shielding within this group, and that is appropriate. But we have been able to return significant numbers of shielding staff back to work in alternative roles. and indeed where a high risk assessment has been undertaken, we've obviously taken advice in conjunction with occupational health colleagues in terms of alternative roles for people. So that's a significant progression, I think, in that piece of work, and a huge amount of effort from operational teams to get through the 800 or 900 of those risk assessments. The challenge we've now got is that we're being asked to undertake the risk assessment for all of our staff, all 12,000 of our people. So we're currently working through that with teams at the moment. I think we're approaching the 50% mark on that at the moment. So almost 6,000 of those undertaken, which is no mean feat, but we're working towards completion of the broader risk assessment. In terms of then the network, so as part of our work on this particular agenda and our broader equality work, we have actually established a new BAME network. We've had a fantastic response from colleagues within the organisation on that. And actually we have got over 100 people now engaged in our BAME network. Which is fantastic, the level of engagement that we've had. So what we intend to do with that really is to make sure that that contributes to the board's diversity and inclusion agenda, and essentially the network will have a couple of functions, which will be to act as a resource for the health board to provide guidance on BAME workplace issues, influence and impact the health board's activities in relation to BAME staff, and really just ensure that we've got a safe and supportive workplace for BAME members of staff to be able to share challenges, experiences and learning, all with a view to improving our position as a BAME employer to the level that we are. So those are the two main issues in the report, and I'm asking the board to note the progress undertaken in relation to the risk assessment and indeed the progress on the BAME network.
Thanks very much, Hal, and a number of comments from colleagues coming through, thanking you and acknowledging the very real progress and useful developments that you've just described. Thank you very much. Colleagues, I can't see any additional questions, so that's good. That speaks to the clarity of the paper and the presentation. Thanks, Hal. And then moving on, item 3.5.2. Yet another, I seem to be saying this rather a lot today, another crucial element in the health board's journey towards where we want to be in the future, the values and behaviours work. And Hal, again, you're leading on this one. Over to you.
Thanks again, Marcus. So again, I'll assume board members have read the paper, so I won't take you through the history of this this piece of work, because I think I gave a fairly presentation on that at the last board meeting in July when we went through that. But essentially what this paper is intended to do is to provide an update to the board on how we're progressing the work around values and behaviours. And there's a couple of elements to that. So there's the launch element of it, and you'll have seen some comms have gone out recently on that across the health board's comms channels, and indeed on SharePoint for staff to access. And I know a number of the independent members have accessed some of that comms material and have provided feedback, which has been really positive. We are at the moment just taking some feedback on the launch, so you know we can't shy away really from the circumstances we find ourselves in terms of the resurgence and potential for second wave in the pandemic. So you know there's no good time at the moment to do this kind of work, which is a little bit more developmental perhaps than the emergency response that we find ourselves in. However, this is a key issue for us, and indeed you could argue more so at the moment with what might be upon us going into the winter. So we are just taking a little bit of a pause and feedback from staff in terms of how is this landing at the moment within the organisation, and indeed is it becoming lost in amongst the variety and the volume of comms that we're currently putting out to staff and to partners and to the public in terms of our COVID response and some of the issues that we're experiencing. So we'll continue to do that. We've got a bit of a questionnaire that we're posing to some frontline staff this week just to understand their feedback in that regard, and then we'll take stock. However, the work in terms of embedding the values and behaviours, my team continue to work through, and that is really about weaving the values and behaviours framework that we've come up with into all of our systems and processes, right the way from PADRs and appraisals through to decision making, leadership and management development, etc., all as detailed within the paper. We also, at the same time, you'll be aware from my presentation in July, are partnered with an agency who are assisting us to develop some visual materials so that we can bring this to life with our people, which I think is quite an important part of the work that we're doing. That work continues, and again, we will share that with board members as and when that becomes available. So there is a little element to the report that's been provided as well in terms of the leadership challenge for all of us, I guess, as senior leaders and board members within the organisation under section 3.2. So some key challenges for senior leaders within the organisation, really broadly around role modelling and upholding and demonstrating the values and behaviours, talking about them as part of our everyday work, ensuring the values and behaviours are brought to life in departments and embodied by teams, and then all of that really then using the values and behaviours work, which is ultimately why we've done this work, as a catalyst for creating positive cultural change throughout the organisation. So that is a leadership challenge and a responsibility, I think, for all of us as senior leaders within the organisation and board members. And you know, there's a quote that I always kind of peddle when I talk about this, which is that you know, these are really important values and behaviours, and we should try and live them all of the time, not just when things are going well, because I think if we do that, they're not values and behaviours, they're more hobbies. So this is a really important challenge for us as leaders. And in terms of the paper then, Marcus, the paper's asking board members to note the progress made in relation to the values and behaviours.
Thanks, Hal. That's very helpful. Jane, come to you next.
Thank you, Chair, and thank you, Howell, for the account of the progress that is being made in this area, which is very good to see. Because values and behaviours work, nice to have, perhaps, but actually it's a really important part of our response to the targeted intervention that we are in as a health board, and has a real impact on how staff relate to each other and to our patients and communities. So you've given us an indication of where we are. Am I right in thinking that we're going to have a full implementation plan at the next People and Culture Committee?
Yes, absolutely. So as I said, Jane, I think we need to just take a quick reflection over the next week or so. My team are currently doing this with frontline staff just to see how things are landing at the moment, and in terms of the timing, just making sure we're getting that absolutely right. But yeah, absolutely plan to bring an implementation plan and update to the People and Culture Committee, which I think meets towards the end of October.
Thank you.
Thanks, Jane. And doubtless, Hal, that will include how we're intending to measure the actual impact of all this, because as we've said, it's vitally important that the work is done, but even more important is some sort of reliable indicator that we are starting to embed, because that is always the sort of challenge, isn't it? But I'm sure that will be included in the implementation plan.
It will indeed, yeah, and we've done some extensive research around culture measurement, Marcus. I think I mentioned at the last board, culture is not a straightforward thing to measure, but there are some good indicators and good measurement that exist for healthcare organisations in particular. So we've done an extensive piece of research on that and are proposing some measures to enable us to do that in a more structured way as part of this work.
Super, thanks. I'm going to go to Nicola and then to Paul Mears. So Nicola, you next.
Thank you, Marcus. It's just to pick up on Howell's little speech there about how we're going to measure, Marcus. We do have a meeting today of the project group for the values and behaviours, and one of the things we're going to be looking at is the 3 or 4 questions we can compile, which will give us a sense of, are staff actually seeing the differences? Are they feeling the differences? Are they behaving in a different way? So much as a lot of the comms, I think, has been lost in what's going on, we are continuing to work at pace, and we do meet at least twice a week to discuss any progress that we are making. So just as to assure people, there's still a lot of work going on.
Thanks, Nicola. That's and your engagement in that, I think, is also very, very helpful as well. Thank you. Paul Mears, come to you next, Paul.
Yeah, thanks, Marcus. Just also to reiterate really what Hal said, and to be fair to Hal, some of this sort of slight sort of approach is me sticking my oar in as the new boy, asking a few questions. So the point about sort of just testing it out with a few people, I think having been around the organisation for the past few weeks and had quite a few chats with lots of different people, I think clearly there is a real pressure point for everyone at the moment. And Hal and I were having the conversation about the challenge of how do you land a pretty major sort of programme of work in the organisation at a time when everyone is feeling very, very, stretched, and frankly just wants to get to the end of the shift and get home, and isn't really going to want to sit down and sort of have a big conversation about values. So I think what I suggested to Hal, and Hal I think is now doing is just testing out with a few key people, managers, frontline clinical staff. What's the best way to communicate this stuff to you? Is it better to do sort of online, quick Q&As? Is it better to send stuff out to you by email? Is it better to do it through Cascade? And I think hopefully that will give us a bit more of a feel from people on the front line about how they want to receive the information, because I think sometimes these sorts of things, it's great, we can think that we know what people want to receive and how they want to receive it, but perhaps testing it out with a few key people first is a really helpful way of just making sure that we do it as effectively as possible, so all the hard work that's gone on to date is really successful. And I think it's a really positive programme of work, and I think people like Nicola and union colleagues are key in helping us disseminate this information. But it also really ties back into things like leadership development programmes, because I've, in my experience, found these sorts of things live or fall by middle managers, team managers, ward managers. The people at the very top can say one thing and the staff can say that what they want, and if you haven't got that tier of middle managers in who are the ones who are day-to-day liaising with their staff and dealing with their staff, really involved in this and understanding it, I think that can be often where it falls over. So I think the little bit of time we take with some of those key people testing it, I think will be valuable in the long run.
Thanks, Paul. That's very helpful indeed. Hal, anything else you wanted to leave us with?
No, that's it for me. I think I support everything that Paul has said there, and we are on to that work at the moment, and we'll feed back as soon as we have something to on that front.
Super. So again, just to reiterate what the board has said all along, this is absolutely crucial building for the future. It's not a quick fix. This is long-term, continuous work, I guess, really, but absolutely fundamental to pretty much everything that we've discussed on this agenda. And it's great to see your commitment, Hal, and Paul's commitment to this, because this is a long haul, isn't it? This is going to require us to be on this case for some time, but doing it in an intelligent and sensitive and responsive fashion. So thank you very much for that. Right, colleagues, we're nearing the end now of the meeting. Item 4 is items for information. You can see there the 4 items there. I'm not proposing to linger over these unless anybody has anything specific that they wanted to raise in relation to items 4.1, 4.2, 4.3. I'm not seeing any indication that you do. Any other business? Just one item that I'm aware of. So the George, could you just update us on the recently sort of mooted arrangements for the follow-up of the joint HIW Audit Wales quality governance arrangements. Can you update us, George?
Certainly, Chair, thank you. So, yeah, apologies again, this wasn't on the agenda. We only received notification 2 days ago from HIW and Audit Wales that they will intend to come in to conduct their review of the quality governance arrangements. So you will recall that in November last year they published their report. This is the follow-up review. They will be wanting to speak to all board members, but what they also want to do is test how quality governance arrangements are being evolved and maturing at a sort of more operational level. So they'll also be linking in with the locality groups as well. So the plan is that they will be in between sort of October, November time with a view to publishing the report around January. So I just wanted to make the board aware. Thank you.
And they're taking surgical services as their sort of indicator area, George, again?
Again, yes. So you recall again that they focus specifically on surgical services for the staff survey, and they'll be rerunning that, I believe. Yeah. Super.
Thanks, George. That's very helpful. Good. So, colleagues, I think that brings us to the end of the agenda. Thank you very much. Another packed agenda, lots of very important issues there, and a sense that the world is moving on as we sit here almost. So thank you all very much. We have our annual general meeting, which we're also going to be live streaming in an hour's time, I think it starts. Colleagues, thank you for this meeting, and a warm invitation to anybody who wishes to join us at 2 o'clock for our annual general meeting. Thanks very much.
Thanks, Marcus.